Hey everyone, and welcome to This Explainer. Today, we're taking what can often feel like a massive, totally overwhelming medical topic, and well, we're going to break it down. We're turning it into a clear, predictable, and actually really empowering chronological roadmap. We're talking about the clinical journey of gestational diabetes. We'll be drawing straight from the rigorous clinical guidelines set by NICE and the RCOG to figure out exactly what this condition means for expectant parents. So, whether you're navigating this journey yourself right now, maybe supporting a partner, or honestly, you just love a highly structured medical deep dive, you are in the perfect place. Let's get started. Okay, let's dive right into this. Here is our roadmap. We are going to start by defining exactly what gestational diabetes is, then we'll move through screening and diagnosis and understand the risks. After that, we'll open up the management toolkit and finally take a look at delivery and postpartum care, completely manageable.
All right, section 1. What is gestational diabetes? We really need to define the starting line here.
The absolute most critical part of this definition is understanding the why. Gestational diabetes mellitus, or GDM, is basically a glucose intolerance that's diagnosed for the very first time during pregnancy. Usually, it pops up in the second or third trimester. Now, notice how placental hormones increase insulin resistance. The placenta is this miraculous life support system, right? But it's also a bit of a hormone powerhouse, and those hormones naturally block the action of the mother's insulin. For some women, their bodies just can't produce enough extra insulin to overcome that resistance, which leads to higher blood sugar. So I want to be super clear here. It's literally just biology doing its thing. It is not a personal failure.
Moving on to section 2, screening and diagnosis. Let's see how doctors figure out who needs testing and when. So doctors use a specific risk factor-based mental checklist to figure this out. A BMI of 30 or higher, having had gestational diabetes in the past, or maybe delivering a previous baby that weighed 4.5 kilograms or more, those are immediate flags. They're also going to look at family history, specifically if you have a first-degree relative with diabetes. And they look at ethnic backgrounds that just naturally carry a higher risk, like South Asian, Black African, African Caribbean, Chinese, or Middle Eastern descent. Finally, they check for glycosuria, which is just glucose in the urine. Having literally any one of these factors simply flags a need for proactive screening. That's it. Now, for the vast majority of women with those risk factors, the sweet spot for screening is right between 24 and 28 weeks of pregnancy. This is when those placental hormones are really peaking. You'll go in for a 75-gram oral glucose tolerance test, or OGTT. Basically, you drink a very, very sweet glucose drink, and then there's a 2-hour wait to measure your plasma glucose. But for those who've had GDM before, doctors don't wait for that 24-week mark. They'll initiate early self-monitoring or an early OGTT right at the very start of the pregnancy, just to stay ahead of the curve.
And here is how they actually make the diagnosis based on the NICE and RCOG criteria. It's incredibly objective. They check your fasting plasma glucose, which needs to be under 5.6 millimoles per liter. Then they check that 2-hour mark after you've had the glucose drink, and that needs to be under 7.8. The rule here is super simple. Hitting or exceeding either of these numbers confirms a diagnosis of gestational diabetes. It gives both patients and doctors a crystal clear, objective starting point so they can begin treatment right away.
Okay, section 3, understanding the risks. Now, what's really interesting about this part, it's really important that we look at these clinical complications honestly because, well, knowing the risks actually empowers us to prevent them. We can neatly compartmentalize these into maternal and fetal categories. For the mother, risks include things like preeclampsia, polyhydramnios, and an increased likelihood of needing an operative or cesarean delivery, plus a higher risk for future diabetes. On the fetal and neonatal side, that extra glucose can lead to macrosomia, which basically just means fetal overgrowth. And that overgrowth increases the risk of shoulder dystocia during birth, as well as neonatal hypoglycemia or jaundice, which could potentially mean a NICU stay. But wait. The absolute critical distinction here is the word uncontrolled. Severe complications like birth injuries or worse are heavily tied to poor glycemic control. And honestly, that is incredibly good news because it means that with active management, you can powerfully mitigate these risks. You have agency here. This is totally manageable. Which brings us to section 4, the management toolkit. Think of this phase as a highly supportive, scalable safety net designed to keep both mom and baby completely safe. The toolkit starts with education, so meeting with a dietitian and looking at medical nutrition therapy. And interestingly, something as simple and accessible as a 30-minute walk after your meals, it's a profoundly powerful tool to help your muscles just absorb that excess glucose. Patients will also start home blood glucose monitoring. And on the clinical side of things, care gets upgraded to consultant-led obstetrics. And that includes regular serial ultrasounds to keep a close eye on fetal growth and amniotic fluid levels.
So, the crucial point is, how do we actually know the toolkit is working? Well, we use these exact targets established by NICE. To achieve good control, expectant mothers aim to keep their fasting glucose under 5.3. 1 hour after a meal, the target is under 7.8, and 2 hours after a meal, it should drop back down under 6.4. Having these exact, defined metrics, it's huge. It puts the control firmly back in the patient's hands.
Now, I want to emphasize this. That fasting target of 5.3 is the ultimate morning baseline. If you wake up and your baseline is already too high, it becomes so much harder to control the spikes after breakfast, lunch, and dinner. Achieving this fasting target is honestly often the hardest part, but it absolutely sets the physiological tone for the entire day.
And look, if diet and exercise aren't quite enough to hit those targets, we simply move to an escalation of support. Step 1 is always diet and exercise. Step 2 introduces a first-line medication called metformin, and if glucose remains stubbornly high, or if the ultrasounds are showing that macrosomia we talked about, step 3 is insulin. There's this really common misconception that needing metformin or insulin is somehow a failure. No way. Actually, scratch that. It's really just a proactive escalation of support to match the very specific physiological demands of that pregnancy.
Finally, Section 5, Delivery and Postpartum Care. The final chapters of the journey.
The timeline around delivery is very carefully planned. If the gestational diabetes has been uncomplicated and well-controlled, the target is usually to give birth by 40 weeks and 6 days. During labor itself, maternal blood glucose is continuously monitored, and if necessary, an IV infusion is used just to keep levels nice and stable. Now, delivery must take place in a hospital equipped with neonatal facilities, because once the baby arrives, the absolute immediate priority is early neonatal feeding within that first hour and then every 2 to 3 hours after that. This frequent feeding is absolutely essential to monitor the baby and prevent low blood sugar, now that they are no longer getting that continuous high glucose supply from mom. Okay, so once the placenta is delivered, the primary source of that insulin resistance is totally gone. First on our postpartum checklist, you get the immediate relief of stopping those glucose-lowering medications like metformin or insulin. Before leaving the hospital, the mother's glucose is checked one more time. But the journey doesn't end right there. A really crucial follow-up diabetes test is performed at 6 to 13 weeks postpartum to make sure the mother's body has fully reset. Doctors are also going to provide counseling on weight loss, diet, and future pregnancy planning, and they'll recommend annual diabetes screening going forward.
But why the annual screening? Well, the statistics are kind of staggering. Up to 50%, so 1 in 2 women who experience gestational diabetes, will go on to develop type 2 diabetes within just 5 years. On top of that, more than 1 in 3 women will face gestational diabetes again in a future pregnancy. It's a heavy statistic for sure, but it perfectly underscores why the postpartum follow-up is arguably just as critical as the prenatal care.
Which brings us to our final thought, a direct takeaway straight from the clinical guidelines. Gestational diabetes highlights the need for lifelong follow-up. What starts as a temporary condition caused by placental hormones actually serves as this crucial predictive window into a person's metabolic health. It really begs the question, if pregnancy acts as a sort of metabolic stress test, how can we better use these early warning signs to completely rewrite a mother's long-term health narrative?